lung talk, which I think we're kind of calling now, is a little lung talk with yours truly, Alexander Grachewin. For those that do not know me, I'm Alexander Grachewin. I'm a respiratory therapist by trade. I'm the executive clinical director for HRN, where we provide pulmonary and cardiac rehabilitation. So a lot of the patients have to go through me first to look at care plans, doctors. First Dr. Shaw, of course, then me, and I look at a care plan that Dr. Shaw writes out, or any other doctor that writes out, or referring doctor that writes out. Anyways, as we kind of get started here, I have some demonstrational devices here, and of course, a mannequin that we usually use for a trach. So we do a lot of trach teaching, tracheostomy types of education and things like that. So anyways, so I want to kind of demonstrate CPAP and BiPAP a little bit, just because there were some people that had some difficulty with compliance, and if this feels like this is you, then we're going to kind of go over a lot of things that, today, we're going to go over a lot of things that will help ease the comfort with different type of modalities, from nasal decongestions to BiPAP, CPAP usage, the definition, the demonstration of what it is, and also some other things, of course. While I'm doing this, I'm going to be showing you this. Please write up any questions that you want to address to me about any topics with pulmonary. It doesn't have to be specifically about CPAP and BiPAP. You can mention or ask any types of questions like I mentioned in our last feed. So, on Tuesday. Oh, is it on? Like right there? Perfect. Thank you. So, as we kind of get started, hey, how you doing, Catherine? So, as we kind of get started here, so what I have here is, and my face might be cut off a couple times, that's okay. What I have here is a tracheostomy dummy, okay? Tracheostomy dummy. So, we use I hate to say dummy, we'll just call him, I don't want to use a name, because then if I say Bob or something, they're going to think everyone who's Bob is a dummy. So, we'll just call this person, that's this mannequin. We'll just call him mannequin, okay? All right, so this mannequin we use for a lot of demonstrations. Okay, so with the demonstrations I'm about to show you, I'm going to go over some basic, typical assessments that I would usually do with a patient if I was going to go to their home, or if a doctor discharged them, or a hospital discharged that patient with a BiPAP or CPAP and the person doesn't know what to do. Or I will also show a demonstration of a general assessment, a generalized assessment, okay? All right. One thing about, before I go into this, one thing about peer review, using clinical people to help and work with when you're in rehabilitation. A lot of people will try to go into a gym or try to do things themselves, which is great. It's independence. Yeah, that's great. But there's a reason why somebody needs a clinician. Okay, there's a reason why. Major reasons why. For very educated people, obviously this is very common sense. This is perfect, just common sense. If I go into a gym, and let's say I was going to do some cardiac rehabilitation, and I learned on a website that I wasn't sure if it was a very good website or not, but I saw some techniques, maybe off of an app or maybe off of something else. So I go into a gym, and I see a higher heart rate. As a person that might not know, I don't know if that's a good number or not. I don't know that I am close to I'm about to have a heart attack. I don't know that. I don't know that oxygen should be dropping down sometimes and coming back up. I don't know that, the repetition or a leg problem or a back problem could actually interfere with some of my rehabilitation. When you're working out legs, let's say you're in for pulmonary rehabilitation, but you didn't go in for a pulmonary rehab. Okay, let's just say you didn't go in for pulmonary rehab. So you're doing pulmonary rehabilitation for yourself using what you can without the guidance of a clinician. So when I see an oxygen drop, I know what to do, right? Because that's what I do. I will coach the patient and show them, with demonstration, show them of how to breathe with that exercise. I will see that, okay, you know, somebody looks at their pulse oximeter, they see it's 73%, I should call the 911 type of thing. I'm like, well, check fingers. Like, switch your pulse ox from one hand to another hand, and one shows 73 while the other one shows 96. You know, that's what clinicians do. That's what they're trained to do. You know, they're not looking at a low oxygen. They're also thinking, all right, let's think about temperature. Let's think about the oxygen quality. Let's look at humidity. Let's look at, you know, poor circulation throughout your hands. You know, we're looking at all sorts of aspects, not just like, okay, here's the pulse ox, here's that, and that should be good to go. No. The reason why I use clinicians is because of their expert advice and their expert experience when they perform pulmonary rehabilitation or assessments and things like that. Anyways, so it's very important to use clinicians. What I'm going to show you here first, before I show you BiPAP, CPAP compliance and what is it and what does it do type of thing, let me show you a general assessment. Okay? This is an assessment you can actually do at home on somebody you know. You know, it's like a friend, a relative, you know, a neighbor, or whatever. So let me show you a demonstration here. So I'm going to turn this to the side a little bit. Actually, this might, because this guy's very heavy and this stand I don't think can stand with the weight. So let me just lower this camera down so you can see this a little bit better. Okay, and I'm going to zoom in just a little bit, just so you can see this a little bit better, just because this stand I don't think can hold such a heavy weight like that. That's okay. All right. So what I'm going to do here right now is there's a line on the back. Does anybody know the reason why there's a line on the back? Does anybody know the reason why there's a line on the back? Why would we put a line on the back? Because that's the center of the spine, right? Center of the spine. So let's say you're assessing somebody, let's just say, you know, a clinician's assessing somebody, and what we would do is we'll take two thumbs and we'll put them, first we'll put our fingers around the auxiliary, underneath the armpits, and we'll put our thumbs about almost like a 2-inch spread, so 1 inch on one side, 1 inch on each side, which is a total of 2 inches. As the person breathes, okay, I will notice as they breathe, let's say one side is inflating more than this left side. That means the possibility there could be some high consolidation, could be severe atelectasis, could be a pneumothorax, could be fluid filled, could be all sorts of things. Could be fibrotic tissues that are more severe on the left side than the right side. Or maybe the left side is moving more than the right side. So when we do a general assessment on somebody, we want to see how the lungs are actually inflating. If I see one side's going up, I'm going to be concerned because this side's not moving very much. Or let's say this side is moving more, but this side's moving a little bit. So I will concentrate my therapy on that patient, specifically on that left side, making it as equal as the other side. Does that make sense? Okay. Now, if I was going to perform chest physiotherapy, this is kind of like a crash course in a sense, but if I was going to perform chest physiotherapy, common misconception is you would slap the back like that. That's not how you do chest physiotherapy. You would cup your hand, not flat, cup it, causing resonant sound. So what I would do is if I'm patting, just like this, I'm not going very hard and aggressive on this patient, right? All I'm doing is vibrating the chest fields to help mobilize the congestion, to help mobilize it so that person can bring it out. Let's say a person has that congestion, but doesn't have the ability to cough it out or can't pat their back like that, you know, and they're having a hard time. So there's different ways we can help somebody, especially from their own home. We can have the person actually lay flat, if not a little bit elevated, like maybe a pillow underneath the hips. And what's happening here? Gravity is going to start sliding the congestion down. That means this is called postural drainage. Postural drainage. Now, let's look at a lung. I attached a I attached a BiPAP here, okay, or a PAP device. Let me share with you something here. This is going to be very interesting. Okay. So what I have here, pretend this is a lung. Just pretend this is a lung. Okay, right now there is pressure. As you see, this is already inflated. Somebody on a CPAP or a BiPAP, this is what they would see. This is how they feel. Their lungs will stay inflated because that's continuous positive airway pressure. So when does the bi level kick in? As soon as I breathe, watch the bag expand. It expands further. It expands further. So what is the difference between a BiPAP and a CPAP? Well, besides the acronym bi-level versus continuous positive airway pressure like CPAP, the difference between it is CPAP gives you a continuous airway pressure. Okay? A continuous airway pressure, keeping pressure in the lung fields. And just like Charles' law, Boyle's law, Gay-Lussac's law, you know, where high pressure, you know, follows low pressure. So right now, if there's oxygen in there, because of the pressure, it's going to force and splint the airways that might be collapsed when somebody's asleep. That happens when your muscles relax. We rely on the muscles we have to breathe throughout the night. So anyways, so just pretend that this right here is an actual, let's say this is the muscle. This tube represents the muscle, my diaphragm and intercostal muscles. This is my lung. Right now, don't pretend it's on a BiPAP. Okay, I'm just showing you on a lung really quick. So continuous positive airway pressure is going to keep it inflated. If I turned off the machine, this will deflate. I attached a rubber band to create some elasticity, as lungs have elasticity. It's a fiber in the lung parenchyma, this pink stuff right here. All that purple pink, you know, that pink, that's called lung parenchyma. Starts with a P, parenchyma. So that's made out of a collagen fiber called elasticin. All right? It makes the lungs very elastic, just like a balloon. So watch this now. So right now, let's say I'm on a BiPAP. Okay, let's just pretend really quick. I'm on a BiPAP. Every time I initiate a breath, it's going to push a little bit more air into there. So it's giving me two pressures now. One pressure, which is a CPAP, to keep it a continuous positive airway pressure inside the lung fields. Now, as soon as I initiate a breath like this, as soon as I want to breathe, even a little bit, it'll inflate more, giving me a higher pressure. Okay, now, let's say the patient isn't going through any type of pulmonary rehab, is not doing bronchial hygiene, is not doing respiratory muscle training, and the lungs overall time will get worse as COPD, specifically COPD, or even, let's just say fibrotic tissue, okay? Pulmonary fibrosis, idiopathic pulmonary fibrosis, you know, so let's look at both of them together in a sense. Your lung, perfect elasticity, now there's some scarring in there. Let's just pretend we're going to add some scarring. So I'm going to add another rubber band to it to demonstrate, to kind of show you that there's some more scarring on the lungs now. Okay? And let's say you have some more severe scarring. So I add another rubber band to it. And the rubber bands represent the fibers that basically, when you look at a chest x-ray, or when we look at a chest x-ray, we see scarring. You know, we see a lot of scarring on the x-rays. There's a lot of medical lingo that goes along with it, but we see a lot of scarring. So each of these rubber bands, except the first initial one, represents some scarring. So right now, I just added a lot of scarring to this lung. I inhale. It tries to inflate it, but it doesn't have enough muscle to open it up all the way. Because right now it's attached to a BiPAP, but just pretend this is your actual lung muscle. Let's say these are your intercostal muscles and your diaphragm. Okay? As I breathe in, my muscles can only supply whatever it can do. So if it's very weak, if your lung muscles are very weak, you're not going to get a very large volume out of it, right? You can't add in a lot of air because of all that scarring. That's a big problem. You can't add a lot of air into it. And depending on the severity of the scarring, if I add more scar tissue, it solidifies the lung, making it difficult to breathe in deep. And as you can see, it's not opening up much. It's just a little bit. Okay? So somebody on a CPAP or a BiPAP, let's say they have a lot of scarring on their lungs. What if we were able to stretch the lungs out, stretch the lungs out, stretch the lungs out, stretch the lungs out? The scarring will still show up on a chest x-ray, but the compliance would be a lot higher, meaning the patient is getting more compliance off of a stiff lung. The lungs are able to expand now because the person is doing lung stretches. The person is doing hyperinflation therapy. The person is doing a lot more different types of exercises, not specifically like walking on a treadmill. You know, like walking on a treadmill. That's not part of your respiratory system. You're walking on a treadmill, that's not part of your respiratory system. I'm not sure what you're thinking that's pulmonary rehab. That's not pulmonary rehab. Pulmonary rehab is specifically for the lungs. Now, we do exercise people with their legs, upper body, and stuff like that. We do. But when we specifically cater to just pulmonary rehab, we're focusing on lung muscles, the lung, circulation, perfusion, everything, blood pressures, everything, oxygen, everything. We're looking at temperatures, weight, ideal body weight, looking at nutrition, every single aspect. And we take you as one individual, as that individual, to be very unique in their whatever the complications they have, meaning this person might need less sodium than this person. This person has more severe lung disease than that person. So we cater each care plan in pulmonary and cardiac rehab as professionals to each individual based off of their complications, as no two people with the same disease is equal in their symptoms. It doesn't happen that way, you know? So, if I increase my lung capacity, meaning my lungs are now able to inflate more and more and more, then of course the scarring will still show up, but my volumes have increased. Does that make sense? You understand? Now, let's say somebody's on a BiPAP and CPAP. Guys, keep writing up questions and I'll answer them in a little bit. Right now, I have this person on a nasal pillow, okay, nasal pillow. There's a couple problems that I'm going to institute that I want you to be well aware of. First off, if I attach this right here, okay, right now, this person is not breathing on their own because it's a mannequin, of course. If they were initiating a breath, let me just clench one of the hoses. If they were initiating a breath, a little bit more pressure from the BiPAP would push into the lung fields, expanding the lungs to ventilate. So remember what CPAP is. Gives you continuous positive airway pressure, keeps your airways inflated. Okay, and then you have to breathe throughout the night. If you cannot breathe out through the night, or you have too much scarring on your lungs, then you fail CPAP trials and you go straight to BiPAP. BiPAP will give you the same CPAP pressure, but it will also do what? Give you another pressure when you initiate a breath, because you can't breathe in or your muscles are too weak because the lung scarring and the respiratory muscles are too weak to actually inflate all that scarring. Okay, so as soon as you try to breathe in a little bit, it will trigger the machine to push a little bit more air so you can ventilate throughout the night. So in a way of saying, BiPAP is a more severe than a CPAP is. CPAP is not as severe because the person can breathe on their own. BiPAP, and there's a lot of reasons somebody would use BiPAP, but BiPAP gives you two variable pressures. You know, BiPAP gives you the CPAP pressure and another pressure on top of that pressure to help you ventilate throughout the night. So anyways, so I have this right here. The only thing is the person's breathing with their mouth open. This might be the most comfortable, and these are very expensive, these types of CPAP masks, you know, or PAP masks. PAP just means positive airway pressure. It could be CPAP or BiPAP. So anyways, if this person is not breathing throughout the night, or is not breathing or keeping their mouth open, because some people sleep like this, Well, the pressure is just bypassing, not going in, not inflating the lungs. It's just bypassing, going into the nose, coming out to the mouth. Because of that, what is this called? Come on, guys, what is this called? What do you think? What is this called? Well, this is called a chin strap. And I know a lot of spouses would love to have this for their spouse, but it doesn't really work that way. So a chin strap, let me take this off here. It's just like so, and I'll show you how to put it on. Goes underneath the chin, wraps up. Doesn't have to be very tight because it'll be uncomfortable and you can't sleep like that. Okay. It'll keep the mouth shut. Right now, it's because this is hard. This is very difficult to close this mannequin's mouth. You know, we use this for demonstration for tracheal tubes too, tracheostomies and stuff like that. So, but anyways, here's a chin strap to keep your mouth closed. So then the pressure can get forced into the lungs instead of going out and coming out for the mouth. If somebody's not very compliant with their CPAP or BiPAP, if they're not very compliant with it, well, on a BiPAP, let's take a look at the machine itself. Now, there's different variations of different machines out there. This is a ResMed, okay? It's a BMC, so this is a bi-level. You can't program it yourself. A clinician can only be the ones to program it, because you could actually hurt yourself or not give you the proper amount of pressure. So on the BiPAP itself, do you see this right here? What is that? That's a basin. That basin, the bottom of it heats up if I add heat to it. So try to take notes if you can, okay? During warmer months, some people don't add a lot. It's not very common to add heat to this, because if you fill water up in here, which is distilled water, not tap water, please. You put distilled water into here, okay? You fill it up to the max line. As it heats up, it creates more humidity as you breathe it in, which is a good thing. It's a humidifier. Very good, Kelly. It's a humidifier, okay? So this is a basin for that. It's a passover humidifier. What that means is air comes in through here, passes over the warm water, and comes out through, well, actually comes out through here, passes over the warm water, and then, of course, transports it to you so you can breathe in humidified air, which is very good. Now, if I had to clean this device, how would I clean it? Sticking it into a dishwasher is not usually the best thing all the time, but if I want to sanitize it, I would actually fill a basin, like a container, that can hold this in fully submerged. I'll fill a basin up with 1 part vinegar, which is acetic acid, and 2 parts water, and warm water. I would wash this with warm soapy water first. Mind you, take this out, okay? I would wash it with warm soapy water first to get any of the major debris that's visible, and then I would leave it into the basin to sanitize it so there's no bacteria, no viruses, no nothing that can live on it. How long should I leave it into the solution for? So the solvent is acetic acid. It's white vinegar, okay? Another name for acetic acid is white vinegar. So I put this into the basin for how long to properly sanitize and disinfect this whole thing. Because if this has any mold on it and I'm inhaling it, I'm going to get infections left and right. I'm going to catch pneumonia left and right. So how long do I leave it into a solution, let's say every week? How long do I leave it in there? 20 minutes. 20 minutes. You leave it in there 20 minutes, then you take it out, dry it off a little bit, leave it to air dry. Okay, leave it to air dry. Now some people use hydrogen peroxide and caught pneumonia really quickly. Why? What does hydrogen peroxide do inside the body? Especially if there's anything left and it's going into your respiratory system. What's going to happen? What is this? What is hydrogen peroxide? Hydrogen peroxide. What is that going to if you have any of it left over and it enters your respiratory system, what could it potentially do? Well, you have normal flora. You have good bacteria that lines normal flora. That's normal. You have good bacteria in your airways. If you add hydrogen peroxide to it, you kill all of that. That means I'm more immunocompromised because why? I just killed all the bacteria that was helping me, that was saving me, that was protecting me. I just killed them. So I don't use hydrogen peroxide, okay? I use hydrogen peroxide for other things, but not when it goes into the respiratory tract. Kills good bacteria. Very, very good. Very, very good. Yes, it does. Yes, it does. Okay? Now, let's say this person, okay, the mannequin, let's pretend this is actually a real person, okay? So this person is saying that I cannot wear that BiPAP. I just can't. I can't wear that CPAP or BiPAP. I just have a hard time. I just feel like an astronaut or a diver or something, and I can't sleep with this whole huge headgear on my face. I'm having a hard time. The pressures are so heavy, and it just blows all this air in my face. So there is a solution, okay? So let me show you some of the solutions here. On a BiPAP, you have what they call a ramp setting, which you should have been told how to use it. What you would do is you would press the ramp. When you start it, you press the ramp button, and it will slowly give you a low pressure purposely. And let's say the ramp setting is at 45, meaning it will give you a slow pressure. Let's say your pressure prescriptions were 10/5, 10 on bilevel and CPAP of 5. Okay, so because that might be a lot of pressure for you, let's say, and you don't like that much air, you would add a ramp setting to it. And what would happen, you can't sleep without it? Yeah. So what would happen is you would press the ramp setting. It would give you a low pressure, like 1 centimeter of water pressure, with good airflow, but like 1 centimeter of water pressure. And then it will, every so often, it will slowly increase until 45 minutes has surpassed. Once 45 minutes has surpassed, it's giving you the full pressure. So it's giving you comfortability. It's slowly adding pressure, making you feel more at ease in a sense. Making you feel more at ease. Okay? So how often should I be cleaning a filter? Well, I'm sorry, the water basin of my humidifier on my BiPAP or CPAP. How often? Anytime, well, it's as needed, but I would usually clean it for my patients once a week, minimum. If I see anything on there, like in a facility where there's other people that are sick, I could clean it every day, but I don't need to do that every single day. But I can. There's nothing wrong with that. Weekly is the highly recommended, not daily. There's nothing wrong with getting daily, Kelly. There's nothing wrong with daily. There's nothing wrong with it. It's just, it might be a little bit too much of an overkill, okay? But it won't hurt you. But I would not do it every month. I would just do it once a week at minimum. So I wash this. I fill it with what, when I add water to it, is it distilled water? Very good. Distilled water only. Distilled water. So I attach this in here. Now it's cold outside. Let's say it's freezing. Let's say it's 30 degrees, it's 40 degrees, it's freezing right now. Well, as I add the water, because it's colder, I'm going to add a little bit more humidity to it by pressing a higher temperature on my humidifier. Because it's cold, and cold lacks what? Humidity. So I'm going to add a little bit more humidity, making it easier for me to breathe and my body to breathe throughout the night while getting some water vapor, a little bit more than usual. And what I mean by that is that during the winter months, or when it's very cold outside, the air quality lacks humidity, The air quality lacks humidity. And do you guys know that pressure increases too during cold? Yeah, pressure increases, okay? When you add water vapor, it spreads out the molecules when you take the water vapor out, it condenses the molecules, creating higher pressure with humidity. That's why a lot of people with lung and heart disease usually go to climates where there's a little bit more humidity. There are some people don't like the humidity at all, which is actually very good for their body and their lungs. They'll try to go to a dry area, but they're getting nosebleeds. They're having a lot of problems with that. But some people actually do just fine in no humidity weather. You know, like let's say Arizona, you know. But then you have a large amount of people like in Florida where there is a lot of humidity. So for Mexico, I had to order distilled to be delivered to the hotel. Hope they can get it right, not just purify it. Yeah, you can distill it yourself. You just have to boil it. You know, you have to make some holy water. You got to boil the hell out of it. That's a little joke. Don't kill me on that one. All right. So I add the humidity. I'm sorry. I add the water to it. I attach my hose. Okay, I'm attaching my hose. I start it. Right now it's on a ramp setting. I only put a ramp setting of 2 minutes, just so because this is demonstrational, really. So in about 2 minutes, it's going to give me full pressure, the pressure that I was prescribed, okay, which is entered into this machine in a different way, which I can't show you because that would be illegal. Let me share something with you here. Let me take this off. Okay, and there's a good amount of air pressure there. So you can see the United States flag. You can see the air pressure is pretty darn decent. Okay, pretty good amount of pressure there. Let me share something with you. What is this? PEP device. PEP device. What this does is flutter. So if I was going to put my mouth over it like this, you hear that noise? That's fluttering. That's going to cause enough vibrations to help mobilize congestion so I can cough it out and bring it out instead of keeping it in my lungs. Let me show you a different way, which I would recommend talking to your doctor before doing something like this, because your doctor doesn't know me, doesn't know, might not know the different therapies, because we teach about 1,700 different exercises and techniques. So there's no program that does that. That's why we are very, very good at what we do, you know, with our success rates, because we really educate people. Anyways, I'm going to take the mouthpiece off of here. I'm sorry, I'm going to keep the mouthpiece on. I'm going to attach the end of this just like that. I can even do that on Arabica. I can do that on a lot of devices. I'm going to attach it to the back end, not the mouthpiece side, but the back end. Now watch what I do here. I'm a person, let's pretend, I'm a person that breathes very shallow and has a hard time removing congestion, and this doesn't vibrate my lung fields as great as it should. So what should I do? Well, if I have a BiPAP, I'm in luck. Okay, if I have a BiPAP, I am in luck. So this will pertain to anybody who has a BiPAP. So right now, same CPAP, I can't change the pressures on this, because the pressures were done specifically based off of my titration study for my polysomnography examination, my sleep study, okay? Plethysmography examination, sorry. So now, when I put this in my mouth, I breathe in. Let's say I can only breathe very shallow. The BiPAP is going to push a little bit more air into my lungs now, because I attached the pressured hose. So when I breathe in shallow, it's going to actually force a little bit more in there. It's going to force a little bit more air expanding. It won't pop your lungs. You're not going to break something, you know, but you're going to breathe in and exhale through it. I can really feel that. I can really feel that. And what's the benefit of that? Well, if I'm only breathing shallow, this will add a little bit more volume into my lungs to help mobilize congestion a little bit more, to help mobilize it so I can pop it out, so I can expectorate it, you know, cough it out. That's one awesome tip. I promise you that. Just mention IPPB to your doctor. Hey, doc, my respiratory therapist or a respiratory therapist that's online has showed me something that I can use as a IPPB, intermittent positive pressure ventilation device. He says attach the VPEP to a BiPAP, and it would be great if I could show you, doc. And what will happen is I breathe in, it's going to add a little bit more air into my lungs. And when I breathe out through the same device, when I breathe out, with this attached, is also going to vibrate my lung fields to help remove congestion out. So they discontinued the Mark II IPPB because there was a lot of contraindications that were not, I don't think, were validated as well, because a lot of the respiratory therapists out there are like, why would you get rid of that? It helps so many people. It's indicated in so many books. You know, why would you get rid of it? And we don't know. Besides, there were doctors and nurses, but there was no respiratory therapists there to make that final decision. And because of that, there is no Bird Mark II. Now, this is not going to be aggressive like the Bird Mark II, you know, of the IPPB device. So this is a lower end, but it does help, especially when somebody's breathing very, very shallow. Okay, it helps push a little bit more air into their body. Pretty neat, isn't it? Okay. Oh, by the way, so I have this device right here. Okay, let me get a little closer here. Let me see how to take it apart. The reason why I like the VPEPs a lot is, first, so this is called a VPEP, in case you don't know. So right here is the VPEP. I can take the mouthpiece off. That's one piece. Take the top cover off. That's two pieces. Take the inner, I think it's called a baffle. Okay, I have a total of 4 pieces. You try to do that with an acapella, you're going to come out with about 1 million different pieces, and it will take you forever. No, I can clean it, Alex. You can't put an acapella into water. You can't. Okay, you can use humidity, but you can't add it to water because mold and water go side by side with each other. Anyways, to put this back, that's all you would have to do. So there's things on here, even on an acapella, which I can show you on acapella if I had a, maybe actually I do have one. Let me see if I have one over here. Yes, I do. Look at that. This right here is an acapella. Now the mouthpiece is not all in there because we don't really use it very much, just for demonstrational use. There is so much meshing and things in there, movable parts inside of here, that taking this apart to try to wash it is virtually, like nearly, very, very difficult, let's just say, very difficult. Back of the acapella, do you see that? Here, see that? Where it moves back and forth? That's your resistance training. So it adds resistance, what we call positive end expiratory pressure. So there's a plus sign, which is hard to see because it's the same color as this. There's a plus sign and a minus sign. So if I turn it left, if I turn it to the left side, which is counterclockwise, it decreases the pressure. If I turn it to the right side, it increases the pressure. Okay? Why would I have to have this on there? Why is this relevant? Well, because if I'm using this device, and let's say I'm breathing out through it, but I feel the vibration isn't very aggressive. It's not doing enough to mobilize that thick congestion. So I'm going to add pressure to it. I'm going to add pressure. I'm going to add positive end expiratory pressure. When I do that, when I add positive end expiratory pressure, what do you think happens? It makes the vibrations more aggressive. So instead of looking at this as a PEEP, like a PEEP device, instead of looking at it like that, look at it as an aggressor. I kind of made that up in a sense, but look at it as an aggressor. VPEP has the same thing, but it's not on the back end of it. It's actually on the top. So on this, if I move it towards the mouthpiece, it's right there. Do you see it? It's right there. See? If I move this towards the mouthpiece, I'm increasing the aggression. If I move it away from it, I'm decreasing the aggression. Okay? Very useful device. I can also attach a nebulizer to knock two birds out with one stone. That's here. Okay, can you hear me? Oh, you got it. All right, you got me? All right, sorry about that, guys. Oops. Sorry, okay, so going back to this. So I got you, I'm sorry. So anyways, so going back to this, I breathe in the medication. You're welcome. I breathe in the medication, a little technical difficulty there. Okay, I breathe in the medication, and as I exhale next, I vibrate the congestion. So I am removing congestion and bringing in medication at the same exact time. So instead of doing it like 10 minutes with this and moving back to this for another 10 minutes, which is a total of 20 minutes, spend 10 minutes to knock out both of them, and you have just 10 minutes to spend to, you know, do anything else that you want to do throughout the day. You know, you just brought in the medications. So very, very nice device. Now, on an acapella, it too also has an ability as a universal 22 outer diameter, that's 22 inner diameter, fits nice and snug into there. Okay, you just have to push it in like that, but that's pretty much it. So it'll do the same thing, except I like, now this is just me, I like the VPEPs. The reason why I like the VPEPs and why I recommend to my patients is they're not as expensive as some of the others. They're not expensive as some of the others. Some of the others are like $100, $150. This is actually like $40, like $45 or something. It's not very expensive. Anyways, and by the way, you can ask your doctor for one, and sometimes your doctor actually has them. They can just give you one, okay? So just ask your doctor, okay? Or if you're in our pulmonary rehab program, we can give you one too. So, you know, they're not free, of course, but they're, you know, because they are very expensive. You know, but they're not, you know, the cost is very, very low. Anyways, very easy to wash. They are dishwasher safe. Same thing with Arabica. They're dishwasher safe. But that's why I like this device. Now, let's take this here. Let me show you something here. Let me show you how much air pressure, I'm sorry, the flow of air. So I'm turning this incentive spirometer down. Let me pick up that camera just a little bit. I'm going to pick up that camera just a little bit. There we go. Okay. Normal, regular incentive spirometer does not have a one-way valve. As you can see, there's nothing there. Other incentive spirometers have a one-way valve. Let me share that with you. Okay, that's the other incentive spirometer. Do you see that one-way valve right here? That means I can inhale air, but I can't exhale air through this device. This one I can. What I'm going to do is I'm going to turn it upside down. I'm going to show you something that a lot of people, and I do mean a lot of people, do not know. Okay. So all you have to just remember on here is that when this is completely vertical, it's from 0 to 4,000. 0 to 4,000. So when it's upside down, just look at the 4,000 as a 0 and the 0 up here as the 4,000. You're just reversing it. Okay? Watch this now. Ready? When I blow air, because this is blowing air, this is not sucking air, blowing air into there, flow meter ball, oops. Flow meter ball goes all the way to the top. This is coming up very slowly. You see how slow it's coming up? Okay. Let me take this out here. Okay. Now, watch when I see how slow it's coming up? Watch this. I'm going to pause it. It shoots it up there really quick. What's happening there? The bilevel's doing that. Now, what if I take a AirLife asthma check? That's this device right here, which measures flow. It's liters per minute. As it states right there, liters per minute. Okay, so I'm going to put this indicator down. I'm just showing you a tip here. I'm just showing you a trick. This is not something you have to do or need to do. I'm just showing you a trick. All right, so that's my indicator. When I blow out, okay, it goes up to an area, however fast I blew out, letting me know there's restriction. If there's a lot of restriction, this would be a lot lower. Okay. Now, on a BiPAP on a ramp, it wouldn't be a lot of flow, but because this has been running past the 2 minutes, so the ramp is over, you can still see it. It's very little tough to see it, but you can see it right there. I'm going to attach this in here to show you the airflow. Where is it at now? $100 liters per minute. That's not a lot. 100 liters per minute. So this is not, BiPAPs are not very aggressive. They add a certain amount of pressure. What if the pressure, because of the lungs, what if the pressure, let me bring this camera up a little bit. What if the pressure needs to be more because my lungs are very stiff and my lungs are very stiff, not stiff. Stiff, and I'm not bringing in a lot of volume in my lungs to BiPAP. Then, maybe I got sick, maybe I had COVID, maybe something happened that caused my lungs to solidify a little bit. So I would need a higher pressure. Let's say, how high of a pressure can I add these, can I use a non-invasive ventilator for? That's a non-invasive. It doesn't go in you. Okay, when I add in an endotracheal tube and I'm using a stylet to open up and put it past the vallecula and putting it at least 2-3 centimeters above the carina, the tube with a cuff, I have to go inside the mouth, and sometimes, depending, I can go through the nose too, but usually the mouth. Anyways, doctors use it, can do it either way, the mouth or the nose. I'm talking about these long tubes that actually get inserted, go all the way down deep. Why am I mentioning that? Why am I mentioning invasive now? When the pressure is too high, the machine can only tolerate, this one and most machines can only tolerate a maximum pressure of 25 centimeters of water. That sounds like a lot. It is. But if the pressure needs to be higher, because the ventilation, when we're looking at tidal volume, the regular, that's called tidal volume. When we're looking at tidal volume, and let's say it's only 150 when it should be way above that, okay, that means we need to add more pressure to get more air into those lungs so that person can breathe throughout the night or breathe throughout the day, depending on their consciousness. Because if you're not conscious, most likely you'll be intubated. Anyways, you would have to be given a ventilator that's an invasive ventilator if the pressure is too high. Okay? And depending on the hospital codes, if you're needing an endotracheal tube to ventilate throughout the night for more than 7 days, they have to perform a what? What do you think they have to perform? A tracheostomy. Because they keep that cuff in there, it's going to decrease venous return to that one area. What I mean by that is, like, if I have here's my skin right here. If I press down on my skin, okay, just the surface of my skin, you could do this right now if you want to, alleviate the pressure. You see all that blood got pushed out? There's a little white spot right there. See that? What happens if I leave that on there for too long? Well, oxygen, nutrients aren't going to that one spot, so right here will start becoming necrotic. Blood is not flowing to that area because it's compressed. Same thing like with bed sores. If I'm on a bed too long, I'm preventing venous return. I'm preventing blood from flowing to that area. I'm going to get some bed sores on my back, on my buttocks, on my, I'm going to get some bed sores. So when somebody's in the bed, there's a lot of complications that can arise. They need to move. They need to be able to move to get blood circulating, or else they're going to have problems. Endotracheal tubes, they get pumped up with about 25 centimeters of water by code. That's our code. 25 centimeters of water by code. And if we leave it in there too long, well, you're going to start getting some fistulas, some dead tissue. And of course, any dead tissue in your airway is a very, very, very bad thing. Because why? If I have a fistula, okay, if I have a dead tissue there, that tissue can break. And what is posterior? What's behind the trachea? Your esophagus. So you get a little small hole that gets larger and larger. Every time you're eating something, you cough like really bad, because the possibility of food entering your windpipe as you swallow, food to liquids and anything like that that you wanted to hydrate yourself or to eat and replenish, it might enter that area. Because of that, we would have to go with a different endotracheal tube that bypasses that area, but we would have to try to fix that area up. So without all those complications, a lot of hospitals on their guidelines are, if somebody has to be intubated for more than 7 days, they have to get trached automatically. They don't need permission per se, unless it was stated before that. Like if you have an NDR, do not resuscitate type of thing. If you have one of those that says do not intubate anything, then that won't do anything. But an endotracheal tube, tracheostomy, not endotracheal. My blood too thick, high red blood cells in iron, so have to get phlebotomy Monday. I got you, Mary. Okay. Tracheostomies. That's a tracheostomy tube. This is a, let me see what size. This looks like a 16. Might be an 18. Inner diameter 10, outer diameter. Okay, so this is a 10. Cannula 7 millimeters. So, by the way, don't ever hold a patient by the neck. It's not. We don't do that. So, anyways, when somebody pops this out because their band that was surrounding them was trying to keep it in place was too tight, and if somebody coughs, they can actually cough this whole thing out. A lot of patients make the mistake of trying to insert this back when they should be going straight back to the doctor, and the doctor has to do it, because we never, ever insert it like this. We don't ever do that, because the chance of it going to the subcutaneous, going into the skin area, that means air is coming in, and you're seeing this big puff of air in your skin, like on your skin, like it looks like a growth, So this can actually be wrongly inserted by inserting it that way. Even though it came out that way, you would think that it should go in that way. No. How we do it, and of course you don't ever do this, would have to put, let me see if I have an arbitrator. So there's an arbitrator that goes on the very end of it. It just smooths it out. It just smooths out the tip by so the skin doesn't pull, or it doesn't pull on anything on the edges of that. It's not sharp, but it just makes it easier. Anyways, I'll lubricate that up. I would actually go from the side, insert it 3/4, twist, and in. That will go in perfectly. And of course, I would take the Posi. This is called Posi. This is the name brand of it. That's the Posi. Okay. Like I said, don't hold people by the neck. Not the right way of doing it. You know, I saw a respiratory therapist once that. Okay, I saw a respiratory therapist once that actually was trying to do a decannulation on somebody and was trying to hold that in place by putting their finger over there. And I was like, what the heck are you doing? What do you mean I'm holding it in place? The person's suffocating to death. They're literally suffocating. You're preventing them from, they're breathing through their neck, not their face. What are you doing? And he's like, oh, I'm sorry, I forgot. I was like, yeah, major rookie. Anyways, that was a rookie. That's a rookie mistake. Don't ever do something like that. When somebody puts these on here, we always want to make sure there's 2 finger of play, 2 fingers. Not 1, but 2. We just put 2 fingers. And if there's some give right there, like if it's too tight, I can feel that, I'll just loosen that up. Because if it's too tight, it'll just be very uncomfortable. Okay. Also, I'll put a 4x4 gauze that surrounds it, keeping the polyvinyl off of the skin. Okay, and on the gauze around the stoma side, I will also, a lot of clinicians don't do this, but I do, because I worked trach care for a very long time, ventilators and trachs, but I'll put some bacitracin around the stoma area to help the stoma. It's like vitamin A, you know, but just bacitracin. Bacitracin, you know what I'm talking about. It's like Neosporin, you know. So I'll add some bacitracin to the gauze, so when I put that underneath the trach, it'll help heal the stoma. It'll help heal the stoma, making it better clinical outcome, especially for when it comes to time for decannulation when that comes up. All right, guys, don't forget, write up questions so I can answer questions. We only have a little bit of time left before I have to shut this off and go back to my patients and stuff like that. But also, we are accepting more bacitracin. Thank you, Mary. That's how you spell it. B-A-C-I-T-R-A-C-I-N. But today we're in my class at 1 o'clock. I have my class right now coming up actually in just a little bit, which I have to head back right now. But if you want to join in or try out the program for a pulmonary rehab program, by all means, just call us up. Just call us. My PFT test without albuterol. I don't know what you're trying to ask me, Mary, but I do have to log off. All right. I have patients I have to see, and I don't neglect my patients. I'll see you guys. All right. That's all the time. If you guys have any other questions. Unfortunately, I don't know what kind of questions you're asking me. It says my PFT test without albuterol. I don't know. I don't know what you're trying to ask me. So if you can clarify that, I can probably answer it afterwards. Okay. But guys, write up questions. Write up questions. Okay. All right, guys. I'll see you guys next time. You're welcome.